the management of advanced urothelial cancers has progressed immensely in the very, very recent years. In fact, in 2023 in particular, and we've seen really pivotal phase 3 data for 2 relatively new targeted therapies. In particular, of course, we've seen extended indication for Enfortumab vedotin, moving from the essentially third line setting up into the frontline setting, where it's clearly the EV302 trial shows that it's having that combination therapy of Enfortumab plus Pembrolizumab is having quite a transformational effect on outcomes for patients in the first line treatment. And secondly, we've seen the pivotal phase 3 data for Erdafitinib, fibroblast growth factor receptor inhibitor, particularly in that cohort 1 from the THOR trial, which is in patients who've previously had treatment with both platinum-based chemotherapy and immunotherapy. But both of these drugs, these newer drugs, so the EV and the Erdafitinib, they both come with new challenges in terms of toxicities. We should be good at rising to new challenges. We're oncologists. It's what we do. That's what makes the specialty exciting, is the fact that there are new treatments. The treatments are changing all the time. So, but there are, as with any new treatment, there are some new toxicities to learn to manage. And of course, management, we need to see that in the very broadest context, because sometimes it's about prevention, sometimes it's about early identification, and sometimes it's about intervening when toxicities do occur. So I'm not going to talk about all of the toxicities of those drugs. I guess if we look at Erdafitinib, I guess there are 2 side effects which maybe are predominant and maybe slightly different from a lot of other drugs we use. In particular, there's neuropathy, particularly sensory neuropathy, peripheral sensory neuropathy, which is quite common. It's probably around half of patients are experiencing at least low-grade neuropathy, relatively small proportion experiencing higher-grade neuropathy, but clearly that can be a devastating toxicity when it occurs at high grade. It's really important that we identify neuropathy early in these patients. That means it's really important to see the patients, speak to them, and if necessary, examine them if they're complaining of any neurotoxicity. And early recourse to drug interruptions, and in some cases having to reduce the dose or even stop the drug due to neuropathy. Remember, it's a combination treatment. It's usually fairly clear cut that when it's the EV that's causing neuropathy, and in patients who have to discontinue EV in the absence of progression, you'd often continue the Pembrolizumab in those patients. Unfortunately, there are no specific measures that can be taken to prevent or even really to treat neuropathy. There are some things that can be done for painful neuropathy, but it's usually loss of sensation is the problem with this drug. The other one we see a little bit of is balance neuropathy causing balance disorder. So it's really important to consider that as well if the patient's balance isn't good. The other toxicity that's caused some issues with EV is skin toxicity. And what's really hit the headlines there is a very low instance of very severe, sometimes fatal skin toxicity with a condition called toxic epidermal necrolysis, or Stevens-Johnson syndrome. Mercifully, I've not personally seen that with EV, although I have seen it with other drugs, and that can be a very devastating exfoliative bullous dermatitis. And it's really important that you have early warning signals for that. So if there's any bullous skin changes, particularly if it's associated with more systemic symptoms such as fever, really early engagement with a specialist dermatologist is really important in that situation. And I would say that if you're setting about using Enfortumab vedotin for the first time, you probably want to go out and make friends with your local dermatologist so that they're aware of the drug before there's a problem. So having said that skin toxicity is rare, skin toxicity overall is relatively common with the EV, and you do have to proactively manage that. And again, it's about appropriate grading, appropriate documentation, and appropriate dose interruption and dose reduction if required. All that information is there in the package insert, so you can read about that. I think there's a couple of clues though in here. So the first is that I think patient education is really important. There's probably not an awful lot they can do to avoid skin toxicity beyond sensible things like avoiding excessive sun exposure and the usual things, looking after their skin, moisturizing, etc. But the key thing is that patients don't often associate rashes with drugs. And of course, rashes are quite common. So it's really important you educate your patients to come and tell you when they're experiencing a rash, because even a mild rash could necessitate an interruption or at least close observation. And I would also say you need to see these patients every time they come for treatment, and you need to examine their skin. Don't wait for them to tell you. I would always look at the patient's skin to satisfy myself that they're not getting rash. Typically, it's a macular rash, often affecting the intertriginous regions, so the elbows and the groin and places like that. So I would always have a look at those places just to make sure that the patient's not developing skin toxicity. Erdafitinib is a totally different drug. It targets the fibroblast growth factor receptor, and there's a couple of things in there that are quite unusual, and they are class effects of fibroblast growth factor inhibitors. The first is hypophosphatemia. Like many of you, I'm not somebody who has paid an awful lot of attention to blood phosphate levels in the past. I think maybe it's helpful not to consider hyperphosphatemia as specifically as a toxicity. It's more a pharmacodynamic biomarker of the drug. So it will always go up. In fact, in the trial and in the US product label, there isn't a European product label yet, you start the drug at 8 milligrams daily and you measure the phosphate on day 15. And if it isn't above a certain threshold, you dose escalate the drug. So you're essentially dose escalating to hyperphosphatemia. So you will see it. You'll always see hyperphosphatemia. Proactively, all patients starting erdafitinib should be given advice about a low phosphate diet. Reactively, again, there are clear thresholds clearly detailed in the US product label, which advise you at what level you need to interrupt and, if need be, reduce the dose of erdafitinib in response to hyperphosphatemia. And also it encourages the use of phosphate binding drugs in patients who are experiencing unacceptable levels of hyperphosphatemia. The second side effect, which is unusual with erdafitinib, again a class effect of the FGFR inhibitors, is this serous choroidoretinitis, which is a form of retinal detachment. It's not quite the same as the sporadic retinal detachments we probably all know people have experienced. And it's often low grade and not sight threatening. So most cases are not symptomatic. But there is a necessity, again, to dose interrupt and sometimes dose reduce or sometimes even stop treatment according to ophthalmological findings. So the key thing here is you need to make friends with an ophthalmologist. You've already got a dermatologist who's your friend helping you out with your EV. For your erdafitinib patients, you need an ophthalmologist on board, because the tests you need to do can't be done in a general sort of oncology outpatient setting. It involves OCT imaging of the retina, for example. So we should be seeing, these patients should be seeing an ophthalmologist before they start treatment. They should be seen once a month for the first 4 months of treatment, and they should be seen 3 monthly thereafter for ophthalmological assessment in order to manage this particular toxicity. But as I've said, these are just learning new tricks. We should be good at that as oncologists. One of the slight problems we have with erdafitinib is that, this is only ever going to be a relatively rare indication, because it's only that 20% of patients who have an FGFR aberration. So none of us are ever going to have hundreds and hundreds of patients on this drug. So we are going to have to pay quite close attention to the detail and following the written advice about what to do for these slightly less expected toxicities that we see with these drugs.